Well, firstly, thanks very much to the organisers for inviting me to speak. I'll be presenting on behalf of the Global TB Programme and the HIV Department at WHO. So I think it's already been really well presented earlier in the earlier session. Prevention should really sit firmly in the centre of universal health coverage. Thank you. And this means leaving no one behind. So the really vulnerable and at risk are prevented from having the disease. Now, if we look at this, this includes reaching across the SDGs to ensure that there's no poverty, there's no malnutrition, there's better education, no stigma, equity, all that in order to prevent. But of course, included in prevention is not just infection control, it's all these things, as well as TB preventive treatment. And we're not going to reach those targets as set out in the NTB strategy, the SDGs, the HIV strategies for ending TB and HIV unless we really seriously scale up TB preventive treatment. So we can see here that scale up of ART has been actually very impressive in recent years. And in fact, to December 2017, nearly 22 million people living with HIV had started ART. And we can see that that's got quite a bit of impact on HIV deaths. You can see the top line is black. It's really steeply declining. But unfortunately, the red line at the bottom, TB deaths amongst people, HIV-positive people, is not really declining nearly as fast. And in fact, 36% of the 1 million AIDS deaths in 2016 were due to TB. So we really need something more. We know, of course, the Temprano trial resulted in 37% reduction in TB mortality after 6 years follow-up. And that was amongst people living with HIV with high CD4 counts and on ART. Yet despite this, there's been really poor scale-up. I mean, this graph shows it. It looks, the numbers, the curves are very, steep. But unfortunately, it only represents 60 countries in the world. That's 60 out of 217 countries reporting. And of the high TB HIV burden countries, only 12 reported last year. Of those that reported, we've also got very poor coverage. Now, this is a little bit complicated, and bear with me, but the blue bars represent those started TB preventive treatment. The red represents those detected and notified with active disease, and the green is the gap between those who weren't on preventive treatment or those who weren't detected. So that's pretty huge, and it really ranges from 86% to 21%, and those are in the top TB and TB HIV burden countries. So we really need to work at these gaps. Now, in 2018, WHO consolidated and updated its guidelines. Previously, recommendations had been slightly dispersed amongst a number of different policies, 6 in all. And also there was a slight misalignment between recommendations in high and low burden settings. So the aim was really to consolidate that and to align it. We had 7 updated recommendations and 7 new, and I'll be really focusing on the recommendations that are focused in high burden settings. The focus of the guidelines is risk group identification, algorithms to rule out TB, testing options, and treatment options. Now, as with all guidelines, WHO guidelines, the guideline development group used the guiding principle that individual benefit outweighs risk as a mainstay of the recommendations on LTBI testing and treatment. So for the priority risk groups, people living with HIV, nothing's changed on that. They still remain a priority group, as have children under 5. There's been the addition of clinical indications for high burden settings, so that's really for HIV-associated TB, nothing has changed. Okay, sorry. The algorithm to rule out active TB in people living with HIV, the great four-symptom screen that we knew in the past and we still use was actually developed based on evidence in low ART coverage, times of low ART coverage. So during the development of these guidelines, the data were reviewed specifically looking at those people on ART and those people not on ART. As you can see here, the sensitivity of screening alone amongst those on ART was only 51%. And if chest X-ray was added, it increased to 84% or 85% close to. So as a result, chest X-ray was added. Obviously, the negative predictive value stayed very high, but this just makes sure that, because clinicians are fairly reticent about providing IPT, and they're worried that they're going to miss those cases. So this is just helps to reassure. But of course, chest radiography should not be a requirement for initiating preventive treatment. For testing of LTBI, head-to-head comparison of IGRA and TST was carried out and found no really statistically significant difference. So it's been recommended for high-burden settings, aligning with the recommendations with low-burden settings. But again, testing is not a requirement for initiating preventive treatment amongst people living with HIV in contacts under 5 years. So for treatment options, the rifampicin, 3-month rifampicin and isoniazid, as well as 3-month isoniazid and rifampicin, was compared with 6 months isoniazid. And it was found to be the rifamycin-based regimens were found to be just as effective as the isoniazid monotherapy, but with lower adverse events and hepatotoxicity and higher completion rates. So that was recommended also in high-burden settings. For preventive treatment for MDR-TB contacts, based on fairly small number of studies, the guideline group decided that, judged that the benefits outweighed the risks, and I think Dick Chasen will speak further on this in his next talk. And it was a conditional recommendation was made, but with the following caveats, that careful assessment was made of each of the individuals, the intensity of exposure, certainty of the source case, reliable information on drug resistance patterns, that preventive treatment should only be given to household contacts at high risk, for instance, children, people on immunosuppressive therapy, and people living with HIV. Drugs should be selected according to the drug susceptibility profile of the source case. Confirmation of infection with LTBI tests would be required, and strict clinical observation and close monitoring for at least 2 years. This recommendation was also not affect placebo-based controlled clinical trials for MDR-TB contacts on ethical grounds. This obviously continued research is absolutely crucial for updating this recommendation. So monitoring and evaluation obviously is key for strengthening any response. And so in 2016, a number of core global and national indicators were developed. And the guidelines recommend that any M&E on LTBI should be aligned with national systems, and that recording and reporting tools should be updated to actually capture the standardized indicators, and that surveillance to monitor resistance to the drugs used to treat LTBI should be firmly in place. Tools also to support, so for instance, digital tools, etc., to support M&E should also be developed and scaled up. So this is a digital tool that WHO has launched this year, and it's free and downloadable on the WHO website. It's adaptable for country-specific contexts and needs. But it's also, it can be used on DHIS2 and electronic reporting systems, and it's functional on mobile devices and can work offline. So it's pretty good for capturing data, the cascade of care from screening all the way to treatment initiation. Now, just a quick word on the patient-friendly regimens that are out there. We all, of course, know that the child-friendly fixed-dose combinations that recently have been made available. And of course, this is a perfect opportunity to scale up rifampicin and INH for children. And then, of course, we've got agreed it's longer, but it's isoniazid, cotrimoxazole, and pyridoxine as one fixed-dose combination scored tablet. So that's on the essential medicines list, and so that's a very good option. And also, of course, there are great opportunities with new evidence coming out of trials for shorter regimens. And so we're watching this space and in touch with the researchers in the hope that we can get something even shorter. So to conclude, programmatic management of LTBI will be essential to end TB and AIDS. Scale up of ART alone will not be enough to end HIV-associated TB. And there are challenges, and they persist, unfortunately, in scaling up, and including in the recording and reporting. These guidelines, and there are a number of other great opportunities that offer new options for catalyzing the TB prevention response. So thanks very much to all my colleagues. Thank you.